Very good. Okay, our next speaker is Dr. Anand Chandrasegaran. Dr. Chandrasegaran is a consultant in anesthesiology and critical care medicine. He has a strong interest in perioperative care for patients and assisting them to manage surgical anxiety and providing a safe and pleasant surgical experience. To achieve this end, he frequently employs clinical hypnosis in helping his patients, particularly for anesthesia and chronic pain care. He has published several papers in medical journals, such as in the Australian Journal of Clinical Hypnotherapy and Hypnosis, an article titled "Using CBT Techniques and Hypnosis for Irritable Bowel Syndrome," and an article on sleep and hypnosis in the Journal of Clinical Neuroscience and Psychopathology, titled "Utilizing Principles of Clinical Hypnosis for an Effective Communication with Patients in Managing Chronic Pain." His talk is about exploring the use of clinical hypnosis with anesthesia. The practice of hypnosis in perioperative medicine has been extensively studied and published in many international clinical papers. Today, Dr. Chandrasegaran will be sharing his personal experiences using hypnosis in managing cases for surgery. He will be sharing videos on some strategies used in eye surgery, venipuncture, and an induction method that he uses, which he calls the ideodynamic induction. This talk will also include the neurophysiological basis of hypnosis in managing patients' pain and anxiety. This talk focuses on clinical applications of hypnosis from the perspective of an anesthesiologist. Thank you.
Hi, thank you, Tom, for a warm welcome. Can you hear me?
Hi, Dr. Anand.
Okay,
yeah, I can hear you. Maybe we need to just bring your mic a little closer to you. Yeah.
All right, I'm going to share the slides.
Yeah, now much clearer. I think the mic has gotten closer to your mouth.
Okay.
Yeah. Give it a share.
Sure.
Remember to click on the share, the sound, and
yeah.
The video.
Is it on now?
Yeah, it's fine. We can see it right here. Yes.
Okay, sure. So
let's go for slideshow and then begin from current slide.
Okay, so thank you, Tom, for the warm welcome, and it's a pleasure to be here. So briefly, like Tom said, I'm Anand. I'm an anesthetist in a hospital here. So my talk today here is about clinical hypnosis in anesthesia practice and my personal experience. So today we'll be covering 6 topics. So what is hypnosis in brief? Evidences in clinical hypnosis in surgical anesthesia and pain management. The neuroscience behind clinical hypnosis phenomenon. Clinical hypnosis for chronic pain, my clinical hypnosis practice in my practice, some methods and video presentation. And if we have time, if time permits, I'll be sharing some examples of hypnotic suggestions for pain relief based on the pain matrix itself. So clinical papers, evidence published. In the following slides, you'll be seeing titles in red, which indicates the research paper, title, journal, and the year publication. So what's for high quality pain management pre and post surgery, it has to address at least 3 aspects. Pharmacological agents, which can help in pain experience itself. Second component is the emotional and mood. And the third component is cognitive functioning. So for experienced pain, for the pain experience itself, a good pharmacological decision can help the patient, such as opioids, non-opioids, anti-epileptic, antidepressant. To manage patients' emotion, such as fear of pain during exercise or even rehabilitation process, a very good psychotherapy or hypnosis approach can help the patient. In a process where patient has maladaptive mindset, cognitive issues, a good psychotherapy and complementary hypnosis can help the patient. In pain, acute or chronic pain, pain is a biopsychosocial problem, which simply means that it involves biological component, pain receptors, psychological component, and social factors. And these 3 parameters, these 3 factors needs to be looked at when handling pain, especially pain in relation to post-surgical healing and also chronic pain. So clinical hypnosis is not a standalone therapy in the treatment of a variety of pain syndromes, especially including inflammatory and neuropathic pain. This is simply because pain is not a biomedical problem. It is not easily resolved using a simple single approach. This has been published in a paper in 2015. For example, what do I mean by this is, for example, if someone has a fracture of the limb, of the radius ulnar fracture of the hand, it's very clear that either he needs a cast or he needs an implant. So there is a very clear process to that. But when it comes to chronic pain, it involves biological component, psychological component, and social component, which varies from individual to individual. So a pharmacological therapy alone may not be the best fit for one individual. So what is hypnosis? Hypnosis is an awareness state, heightened focus and concentration state. It is usually done using verbal repetition, mental images, inducing feeling of calm and relaxed state. So in a paper published in 2015, hypnosis is a normal human situation involving focused attention, reduced peripheral awareness, and it's an enhanced capacity to respond to suggestions. So 3 components here for a good hypnosis process. So various applications of hypnotic techniques, we use it in medical hypnosis to reduce pain, to reduce anxiety during a medical procedure, to facilitate a physiological or biochemical healing process such as wound care. We can also use hypnosis as a form of communication to have effective communication, such as our earlier presenter has spoken his experience in psychiatry. So it's an effective communication tool. And we can also use hypnosis as a form of suggestions for patient going for anesthesia. And I will explain this later shortly. Hypnotherapy has also been used as a form of psychotherapy to facilitate changes, restructuring their cognitive process, and to restructure the emotional stressful events and sensation. This is mainly used by the psychotherapists and psychiatrists. Hypnosis has been widely used in experimental neuroscience research to explore pain, emotional, and state of consciousness. Hypnosis is also used by entertainers as stage hypnosis, but many people and myself think it's not an ethical practice and staged hypnosis for entertainment purposes. So in 2010, Van Monwin came out with this paper, the use of hypnosis instead of local anesthesia in dental surgery and in place of anesthesia for more extensive surgery such as cholecystectomy has been described in various case reports. In this study, in this paper, it has been shown that hypnosis has been shown to reduce pain, anxiety, and the consumption of analgesics and sedatives to a statistically significant extent in patients undergoing operations under local or regional anesthesia. In this paper, it's a paper done to patients with awake craniotomy surgery. This paper illustrates the effectiveness of hypnotic communication. So waking craniotomies are performed in situations to remove certain brain tumors which are close to certain sensitive areas such as speech area or deep brain stimulation. So in this paper, in this procedure, the patients received regional anesthesia around the scalp area and to remain awake for the whole duration of the brain surgery for the purpose of neurological testing with no additional sedation and additional analgesia by simply using hypnosis. So how does the hypnosis help in these patients? So this paper summarized that this association to an inner place of tranquility away from the operating room was an important aspect here, as does the reinterpretation of sensory perception. For example, instead of telling the patient you will be feeling pain, you may be having discomfort. So choice of words was important here. In my study, I've published one study where I used hypnosis in the operating room. This patient was, she has extreme fear towards confined place and coldness. And we all know operating room is very cold and it can be small. So in this patient, she had reaction towards the environment, and we managed to use hypnosis to calm her down. And it took extra time. It took about 30 minutes extra, but it was for the benefit of the patient. In another study where I used hypnosis to manage a patient's IBS problem, this patient had severe pain secondary to IBS, and I used a method called cognitive behavioral hypnotherapy to manage her pain. In this paper published in 2005, language has role in forming experience for patients. So positive language such as relaxation induces calmness to patient. Conversational hypnosis is a form of effective communication. So words matters. Words affects affective state of a particular patient. For example, by simply saying a sharp needle, I'm going to put a sharp needle into your hand, that itself creates pain. Fear, anxiety creates pain. So instead of using the word sharp needle, maybe you can use, I'm going to insert a cannula, a plastic cannula to assist you in giving fluids and medications. So in this paper, 2010, these are the examples of positive waking suggestions used in anesthesia, can be used during induction anesthesia practices. So there are six types of suggestions that we can use. Positive suggestions instead of negative ones. Second one is positive suggestions simply being positive. Third one is combination explaining with positive suggestion. Fourth, providing information about a procedure with positive suggestion. Fifth, reference to patient's autonomy with positive suggestions. And number 6 is providing information about possible complication with positive suggestion. So what do I mean by this? Instead of saying that you do not need to worry, we can actually reframe it, say that everything will be fine. We'll do this together. Instead of saying that you'll be fine, or we can further enhance by saying we'll keep a close eye on you until you've completely recovered from the operation room. So that gives a sense of confidence and positivity to the patient. Another way we can use positive words during anesthesia is we are, instead of saying simply putting the ECG leads or the BP cuff monitoring devices, we will say something like we are attaching a blood pressure cuff and ECG leads so that we can take good care of you. Another way to include would be something like after the operation, you can stay in the recovery room until you wake up naturally. And when you feel well enough, we'll take you back to the room. Other ways will be simply like saying that you can help us to increase the safety of anesthesia by not eating anything for 12 hours before the surgery. So this example gives a sense of patient's autonomy instead of directing or instructing the patient to not eat before the surgery. So that gives a certain, some patients can be very defensive. So instead of attacking their ego, we can actually say that you can help us. Another way to reframe complication, we can use something like, please tell us straight away if you get a headache after the spinal anesthesia. We have good medications for treating this kind of headache. So we are actually priming the patient that you may develop this complication, but we have ways to manage it, which can reduce the anxiety. So far, okay? Can you hear? Can see? Okay, so I'm going to go through neuroscience basis of hypnosis. Just bear with me, it's going to be slightly boring. So neuroscience basis of hypnosis. Oh, sorry. Okay, Julian, can you see my slides?
Hello, hi. Dr. Anand, yes, we can see your slides.
Okay, sorry, thanks.
Not to worry.
Okay, so let me run through very fast, neuroscience basis of hypnosis. So the following slides are based on this paper published in 2007. So there are three main brain neuronal network involved in hypnotic phenomenon. So the three main one, the first one is salience network, which involve the dorsal anterior cingulate cortex, the insula and the amygdala. The second one is default control network, and the third one is executive control network. So just bear with me, we are full of jargons here. So what does this three network does to us? So we have three: salient network, central executive network, and default mode network. So this network interact simultaneously to help us function. For example, the central executive network and the default mode network are anti-correlated, tending to have more control at different times depending on what task it at hand. The salient network, in its role of deciding what is most important to attend to, enables the switching between the two. This high-level network exerts strong suppressing control over lower networks. So what does it mean? It simply means that the salient network decides what is important and what should we be focusing on. And if there is, for example, the salient network detects we are studying for the exam, it is important. So therefore, we will narrow our focus. We have more self-control. We are in problem-solving mode, and we are in rational decision-making. So in this way, for this functioning, the central executive network comes in play. But let's say we are watching a movie and we are having a relaxing day, the default mode network comes into play, where our attention is diffused, mind starts to wander, sense of self starts to be activated, and creativity is predominant here. So what is default control network? So default control network is the part of us where we daydreaming when we're watching a movie. So what it does is an internally directed cognition process. It's active when a person is not focused on the outside world and the brain is at wakeful rest, such as doing daydreaming and mind wandering. It is active during detailed thoughts related to external tasks, for example, watching a movie. It involves thinking about others, thinking about oneself, remembering the past, and wishing the future rather than the task performed. Executive control network, which involve the dorsolateral prefrontal cortex. So this central executive network involves in focus. It's an externally directed cognition. There are a set of cognitive processes that are necessary for cognitive control of behavior. It's turned on when decision-making decides on what to do. It's turned off when it doesn't involve any critical judgment, such as watching a movie. So the salient network, which involves the anterior insular part of the brain and the dorsal anterior cingulate cortex, contributes to a variety of complex function, communication, social behavior, self-awareness through the integration of sensory, emotional, and cognitive awareness. It modulates the switching between the internally directed cognition of the default mode network and the externally directed cognition of the central executive network. Going back to this slide. All right. Basically, a salient network is a conflict detector. It tells us what to worry about, what to pay attention to. It gets turned down when a person gets absorbed in what they are doing, very focused state. It gets turns up its function when we are not focused, attention everywhere, worrying, anxiety, exaggerating the pain response. So how does hypnosis affect the neurobiology of the brain network? Hypnosis disconnects the posterior cingulate cortex, the default mode, which is involved in self-reflection from activity in the salience network, dorsolateral prefrontal cortex. So what does it mean? It means that so that you do not worry about things you are doing. It helps to reduce pain. You do not ignore the pain, but lessen the pain perception. So what does that all mean? A lot of medical jargons here. So it helps you to focus your attention. So you're not thinking about other things. You have better control of what's going on in your body, and you are less self-conscious. In a normal waking state, different brain regions share information with each other. But during hypnosis, this process is kind of fractured, and the various brain regions are no longer simultaneously synchronized in normal state. So what does hypnosis does to a patient? Hypnosis induces an independence among brain region. fostering a segregated connectivity. Because the brain is unable to synchronize communication, hypnotic states are behaviorally inflexible. Hypnotic suggestion can facilitate a process by, and which is not typically present in normal condition. This shift in functioning explains the behavioral changes that we see when a patient is under hypnosis. So hypnosis for chronic pain, how does it help patients in chronic pain? So chronic pain, what is chronic pain? Chronic pain is a neuromatrix suggesting that pain experience has a specific neurosignature that does not activate, is not activated by a single brain region, but rather various brain involved. Is a multi-dimensional nature of pain, meaning that there is no one particular brain area which involves in pain. For example, speech, there's one particular area, but when it comes to pain, there are many parts of us. So pain processing activates the cortical and subcortical network, such as the primary somatosensory cortex, secondary somatosensory cortex, ACC, insula, prefrontal cortex, the cerebrum, thalamus, hippocampus, amygdala. It's a soup of brain area that controls pain. So there's input, cognitive, emotional, sensory, and the output is pain, motor, stress, emotional. So pharmacological agent, for example, pain medication, manages the sensory component of pain. But how about emotional and the cognitive component? So when it comes to pain management, chronic or acute pain, most anesthetists or many of us are trained to manage sensory component, pharmacological component. We are not trained to manage the cognitive and emotional component. Not only trained, in our training, we were not given emphasis on these two main components. In my practice, in chronic pain management, I use hypnosis as a modality to manage cognitive and emotional component to have better output in pain care. Let's skip this. Activation of chronic pain in European Journal of Pain Medicine, published in 2009, studies show that the pattern of activation in chronic pain is related to activation of the corticolimbic system, which involve brain areas that contribute to the affective and cognitive aspects of chronic pain. It highlights the role of emotional and motivational process in the pain experience itself, rather than the sensory treatment alone. In this paper, chronic pain patients display maladaptive behaviors that are thought to be caused by altered attitudes and beliefs towards pain. So in pain management, the transition to chronic pain is marked by a shift in pain from sensory or nociceptive perceptions to emotional cognition. So when there's a shift involving emotional, chronic pain starts to develop. So chronic pain patients display maladaptive behaviors that can lead to pain avoidance behavior, mood disorders such as anxiety and depression, negative pain beliefs such as that I cannot use my arm, therefore I will never do physiotherapy or rehab, and poor global quality of life, where they start to isolate themselves, poor eating habit, and so forth. So what does hypnosis do is hypnosis targets area of the corticolimbic system, thus altering the emotional, motivational processing of pain and the sensory aspect of pain, to a certain extent. The Neuromatrix theory for pain involves pain input coming from various components of the individual. Input from the spinal cord, signals from the brain centers, memories, emotions, expectation, attentions, contributes to pain experience. Modern medicine, modern pharmacological agent only manages input from spinal cord and inputs from the brain centers. Our routine pharmacological agents such as opioids or non-opioids cannot help in memories, emotional, expectation, and attention of pain matrix. So therefore, there is inadequate pain care. So in this paper, 2014, it has been said that the anterior cingulate cortex, ACC, appears to be the key target in the process of reducing pain perception. Hypnotic procedures is the inhibition of afferent nociceptive transmission. So therefore, if we deliver proper hypnotic suggestions to reduce the anterior cingulate cortex function, they can help the patient. So I think we are quite familiar with this definition of hypnosis. 2014, the American Psychological Association states that hypnosis is a state of consciousness involving focused attention, reduced peripheral awareness, characterized by enhanced capacity to respond to suggestions, involving absorption, disassociation, and suggestibility. So going to basic method for clinical hypnosis in anesthesia or surgical management, there is three main areas: induction, therapeutic suggestion, teaching of self-hypnosis, and emergence from hypnotic state. The third phase normally happens simultaneously. So induction state, it helps the patient to relax by imagining peaceful scene, daydreaming. Basically what this do is it reduces the salience network, increase activity in the default network of the brain. The second phase is providing the patient with suggestion. These suggestions are to help the patient to be comfortable, reducing activity in the executive control network. And finally, emergence from hypnosis, helping the patient get back to normal state of consciousness. Hypnotic induction method in paper 1995, it's discussed here. Imagination visualization method, describing a relaxing place, helps the patient to relax by imagining a peaceful scene and becoming more focused on a daydream-like journey. So my practice, I'm an anesthetist in this hospital. So I'm very fortunate to have doctors in my place. We perform surgeries with hypnosis. For example, my colleague here, Dr. Siva, he's a very strong supporter. And other doctors help me in pain management. So how do my practice involving hypnosis, how do I do things here? So number one, the first thing is I decide on the hypnotizability of this patient. I will go in briefly, soon. Once I've decided the hypnotic state of this patient, I will normally proceed to hypnotic induction. I use a term called idiodynamic physiological induction method to help all my induction process. And this is followed by suggestion of relaxation, safe place. And the suggestions are dependent on the type of surgery, dependent on type of surgeon, environment, and the recovery stage. So it's very custom tailored for each individual, for each type of surgery. There is no one particular script which works for all patient or all type of surgery, but there's a general layout to it. For chronic pain, I use suggestions to cover the pain pathway itself, the pain matrix itself. So it's not a random hypnosis script which work for pain, but it's a targeted process. And obviously self-practice, helping the patient to practice self-hypnosis before the surgery. So idio means that idea, dynamic, referring to sensory perception, thought, auditory, others. So it's a process where it's a very dynamic fluidity induction process where the patient actually feels physiological changes and leading and pacing that to induce the hypnotic state. Without actually telling the patient, you are going, example, direct suggestion will be, you will be feeling relaxed. So the patient some patient may not be able to relate the word relax to what they are feeling at the moment. So instead of giving such straight suggestions, so normally I will use, as you slow down your breathing, notice what it makes your body feel. So we all know that when the breathing slows down, we feel more relaxed. And obviously they will say, I feel more relaxed, and keeps on building on that. So hypnotic susceptibility test measures how easily a person can be hypnotized. There are several scales to be used here. The most common one is a Howard Group scale of hypnotic susceptibility and the Stanford hypnotic susceptibility scale. I use the Stanford method. Why is this important? Because there are many arguments to this. Some people say there's no point using hypnotic susceptibility test, but for my practice, I find it very useful because I have limited time with this patient. I need to decide what kind of techniques I can use, whether it be fast or time consuming. And if it's going to take some time, I need to plan the time of the surgeries, or maybe I need additional resources like certain medication. for example, to provide certain sedative state. So deciding whether a patient can be hypnotized quickly or takes time allows me to plan the surgical slot. So my clinical videos, I'm going to share with you some videos on how I actually do hypnosis in my the patients here. So in this patient, what do I mean by idiodynamic physiological induction method? It's a method to allow the patient to focus on the sensation. So let's have a look at the video. So what I'm doing here is I'm raising the patient's arm and I'm getting her to focus on that hand.
All the way.
So I'm going to stop here for a while. I'm just going to share you what I did here. Let me briefly go back. So in this patient, she's closing her eyes. She's very comfortable. Her hand is elevated. But before this stage arrived, I actually allow the patient to feel this first. Obviously, there are two different patients. So when I elevate the hand, I ask the patient, how do you feel? What do you feel in the hand? So use their creative imagination to have certain sensations develop around the hand, and then pace that with their breathing pattern or their heart rate. And once that's achieved, they feel relaxed, and just use their imaginative process to imagine the balloon is lifting up the hand, to feeling more relaxed, those kind of things.
All the way.
So in this patient, I'm about to insert IV cannula. This patient is a very difficult patient to set IV cannula, simply because previous admission, she several times needle were tried to be inserted, was a very difficult way, and she had very bad experience with that, and she can't tolerate the pain. So her pain score out of 10, I would say 10 when it comes to needle prick. So they asked for my help. How can we assist her in helping her to tolerate the pain better? So hypnosis helped me here. So what I'm doing here is, sorry. Let me go back. Okay. So as I'm preparing her hand, I'm talking to her. I'm getting her to imagine certain things. And if you notice that the cannula is there, but throughout the whole process, her eyes is closed. She's very comfortable. The needle is in, and she's relaxed. She tolerated the procedure well, without any medication. All right, this is another patient. He is planned for a surgical intervention for the eye, but before wheeling him, he has also difficult venous access, severe anxiety, low pain threshold. So for this kind of patient, I helped him in the OR itself, preparing him before the eye surgery. Normally, the eye surgeon would do surgeries simply using local anesthesia, but he has contraindication for general anesthesia. So we opted for this approach. So let's see the video how hypnosis helped him. So observe, he's very comfortable. His eyes is closed. He's breathing regularly. He is not concerned about his environment. He's just relaxing. As I tap his hand, I'm getting him to feel the sensations there. And as I'm doing the procedure, I will continue continuously talking to him. Sorry for the background noise. So if you notice, when the needle went in, he didn't move. He was perfectly relaxed. So the same patient, we wheeled him into the operating room. So in the operating room, he already had a positive experience with the IV cannula. That makes things easier for him because it builds the positive connection with inside him that it's going to work. And so in the operating room, before the surgery is being started, again, go through the same relaxation method. So I use the same technique. It allows me to make the patient relax faster, better. So despite all the noises, the background sound, he is perfectly comfortable in his own world. This is a patient who shares her experience with hypnosis.
Post surgery, it was very calm. I don't feel panicky or whatever because I am still aware that I'm being wheeled into the OT and all that. So I am quite. I mean, I'm trying to calm myself, like you say, just calm. And then when when the doctor put the sheet, I can feel he put the sheet above me, but I don't feel like panic attacks there lah. I still can feel some anxiety there, but I am fully aware also that I can control my anxiety. You told me to think of somewhere that is that can make you relax. So I when you told me that some beach, I was thinking of some beach and all that. And then I remember you talking, to calm myself, calming myself, and then you were counting the numbers. You asked me to bring down to which level and all that. So that one I remember also. And then you continue giving words, to make me, be aware of when I'm in my subconscious. Even though I'm in my subconscious, I can still listen to you. Then you told me to be, to just be aware of the surrounding and then to calm myself, to hear all the. It's no harm, because I said before, because rather than use chemical, and
So in this video, I want to share with you the fact that hypnosis is not a sleep process. It's not a state where patient is unconscious. Patient is totally conscious during surgery. She can interact with the surgeon. She can respond appropriately. She can voice out her, whatever concern she has. But it's a state where she is able to control her anxiety. This lady previously, she was planned for the same eye surgery, but she jumped out of the table because severe anxiety, and she has contraindication for general anesthesia. And when she chose this method, she found that she's able to control her anxiety state. So it's a hypnosis in surgery. It's not a state of sleeping, just like general anesthesia, but it's a state where a patient can control his or her state better. And depending on type of surgery, some surgeries we do not use sedative, but if surgery requires sedation or certain local anesthesia, we will supplement them for patient's comfort. And again, patient is awake during the surgery, they can respond, they can, and we can address their issues immediately.
Dr. Anand,
Yes.
sorry, just to jump in. Just looking at the time,
Okay.
we've got about a minute or so left for you to just wrap this up if you're able to, because we have lots of questions to put to you.
All right. So my final slide, I'm sorry, I can't share the other slides, limited time. So basically the steps I use is induction, consolidation meaning that talking to the patient, getting consent, therapeutic suggestion, orientation, post-hypnotic suggestion, discussion, and integration to daily practice by self-hypnosis. So I use this main frame in chronic pain. Sorry, can't share the other slides, limit of time. Thank you so much for your attention.
Thank you very much, Dr. Anand. That was certainly an eye-opener, I'm sure for many in the audience, to see such surgical procedures done without any traditional, pain management. Which brings me on to the first question that I'm going to put to you from Adam. What made you decide to include hypnosis in your armory of pain management techniques?
Simply because I'm well aware that, I think most of us are aware that when it comes to pain care of a person, it's not one component. It's not just the physiological component. It's not a biological component. There's a psychological component. There's a social component. And I've seen in my practice where a person, for example, a 40-kilo man who's going through a minor surgery, by any medical terms, anyone would say it's a minor surgery. So for minor surgery, you need X amount of medication. Should reduce the pain, but for this person, let's say double, 2 times of that X amount of medication. So something else is happening here. Pharmacologically, he should not be having pain. So the normal practice is everyone will tell us pain is upstairs. He's fabricating the pain. He has secondary gain here. So what does our system tell? Our system tells us there's nothing much we can do. But we all know from literature, from studies, there are many things we can do actually. So that's why I use hypnosis in the pain management.
Okay, thank you. Very, very, very enlightening. Dr. Anand, in doing that, how did you explain the benefit of using hypnosis to the hospital and surgeons?
Very good question. How do I explain? Actually, they have to see from the patient's output. Without demonstrating, it's very difficult to get the hospital and surgeons to be convinced. So obviously, initial phase, I had difficulties in persuading surgeons. But when the surgeon, see, I'm in a place where I have to anesthetize patients for surgery or even taking care of chronic pain. So when surgeons refer to me for chronic pain, for example, orthopedic surgeon refer to me for brachial plexus injury, they can't do anything. So they expect me to provide this patient with appropriate pharmacological agent. But instead of providing pharmacological agent, I use hypnosis. And when I educate the surgeons, I'm doing this and the outcome is good, they start to believe there is a role here. And for example, I remember my first surgery with an eye surgeon. This patient has history of severe anaphylaxis against all form of medication. So there is no way she can be induced anesthesia, but she needs the surgery. So we use hypnosis as a way, and she got out very well, fine, no complication. And that's where the surgeon got convinced that there is a role here. It's not an easy approach, not easy to approach surgeons in a hospital, but once they start to buy into the outcome, patients are happy, and it's safe, and there's a fallback plan. For example, if this method does not work, what's the fallback plan? There's plan B, plan C, and so forth. So as anesthetists, we are planned to have plans. If something does not work, we have secondary plan. So does hypnosis work for everyone? Answer is no, it does not work for everyone. So we have to choose our patients right, prepare them appropriately, and if that fails, we have our fallback plan. So if they have that plan, patients be convinced, surgeons be convinced, hospitals convinced, everyone's happy.
Oh, fascinating. And Dr. Anand, another question for you. What impact does hypnoanesthesia have on the amount of pharmacological pain relief that's required post-surgery? So after surgery. After surgery, we have to look at 2 components, patient recovering from the acute pain and patient recovering from the chronic pain, if there is a chronic pain. For example, depending on the type of surgery, for example, if a patient is going for a simple appendectomy, laparoscopically, where they put a camera in and remove the appendix, so there's a component called acute pain only. That does not involve chronic pain much. So in that group of patients, the pharmacological agent is tailored according to the clinical situation. role of hypnosis here in managing that pain is limited. But when it comes to patients with orthopedic problem, for example, brachial plexus injury, so there is role for reduction in pharmacological agent post-operatively. So instead of loading the patients with opioids after opioids, which we all know that opioids is a cause for chronic pain, we reduce the opioid medication, supplement with rehabilitation, psychological approach. Obviously, it has a role in reducing the medication. Amount, percentage varies from patient to patient.
Okay, thank you. And one final question for you, just because of time, not for the lack of questions, Dr. Anand. What is your opinion of the use of the language? For example, before insertion of a cannula, you know, a doctor might say, you know, you're going to feel a sharp scratch, which in a lot of people's minds could suggest pain. What language would you use?
So very simple. Before I even start putting a granular in, they already know it's going to be painful. For us, might be score 3 out of 10, but for this particular patient, maybe 11 out of 10. So the moment that they see a doctor coming in with its needle, the pain is there. So the first approach will be, the first dialogue I would tell the patient is, can you help me to help you, to teach you a way where you can experience differently? So getting a permission for them to help themselves. So when I get that permission, they're already setting themselves for a pain-free process. And from there, the language starts to shift down. So I would say, instead of saying that I'm going to put this needle in, I'm going to say, I'm going to put this plastic tube in to help you to feel better. So the key words here is simple words, feel better. So they will catch on the words, positive words, feel better, to help you to feel better. This medication, this drip will make you feel better as the plastic cannula goes in. So it removes their focus on the cannula, but they focus on the word better, fluids, medication. So if I use the word needle, putting in the needle to give you medication, to give you fluids, the focus is on the needle, equals to pain, equals to anxiety. So shifting the focus is very important. So that's how I use the language patterns. Yeah.
Okay, Dr. Anand. So that's brought us nicely to the time to which I need to hand back over to Tom. But before I do so, Dr. Anand, you know, on behalf of all of us at the LSCCH and LCCH Asia Group, thank you once again for joining us.
Thank you. Thank you.
Been our honour. Would you be willing to, if you were to send, would you be willing to share your slides with our delegates?
Yeah.
Today?
Of course, sure.
Okay, if so, then I'll get in contact with you after the conference, and then we can share them with them. That's fantastic and very kind of you. Thank you again. And Tom, over to you. Thank you, Dr. Anand.